Hi, I'm Dylan Roberts. I'm the Chief Digital and Information Officer from Betsi Cadwaladr University Health Board. With me today, I've got Dr. Ambu.
Sakkarai Ambalavanan, Consultant Physician and Medical Information Officer within BCU.
And Sean.
Sion Jones, Chief Technology Officer.
This is part 3 of 5 of our incremental EPR strategy and proposed approach. This part 3 is about the strategic context and considerations. We've been through some of the problems that we need to solve, but it's really important that as well as solving the problems of today, we need to make sure that any options we choose from an EPR approach or technology or whatever is future-proof and can meet the future strategic needs of the health board. I'm going to jump into presentation mode, and Ambu and I are going to share some of that, and we'll close off with a bit of a discussion at the end. Bear with me as I put the slides up. Okay. So as I talked about, this is about the strategic context and considerations. First of all, we need to be aware of the high-level strategic context and objectives for Healthier Wales. This is the main strategy which looks at how we are going to ultimately deliver on the quintuple aims of healthcare, which is improving outcomes, reducing costs, improved experience, enable equity of access, and reduce staff burnout. The key thing about this strategy is that it looks at supporting the left shift. That is about taking a whole system approach, including the community, all of the organisations in an integrated way, ultimately enabling that left shift whereby we look at enabling people to live more independently, supported by new technologies, and enabling things like self-care, prevention, and enabling community and locality-based assets like independent providers, the voluntary sector, etc., to contribute to the health and care of the individual. This is demonstrated by this diagram here. What you've got on the left there is the patient in the centre, and around the patient you've got the various stakeholders or actors who are working with that patient. You can see family and caregivers, and you'll find that that circle of care is a mix of NHS, social care, independent provision and family. What's really important, an important driver, is that when it comes to the future of electronic patient record systems, we need that integrated view of the patient. Also, we need that integrated view of who's got touch points with the patients, so those people can communicate and work together in effective multidisciplinary teams to improve the lives of that patient and improve the health and care outcomes. The other consideration, of course, is the future of technology and the fact that there are now greater and more diverse digital ecosystems being developed. And in healthcare in particular, there are a myriad of digital solutions, devices and capabilities that are now available to meet the needs of individuals and their personal circumstances and conditions to improve their health and well-being outcomes. They could be around things like monitoring conditions, they could be around enabling things like care in the home, virtual wards, or a mix of different things like that. We need to ensure, as one of the drivers, is that our communities can make use of those capabilities which is available through the digital ecosystems, but also all of the data and those interactions are part of our electronic patient record view. I'll pass over to Ambu now to give the near-term strategic considerations that we need to think about. Ambu.
Thank you. I thought I'll start with talking about the NHS workforce considerations, and I think it's a highly public debate going on about how much we're short of in terms of staffing across the NHS. And here's a diagram that was done before COVID, highlighting significant percentages of people who percentages of shortfalls in different domains within healthcare. And here there's also a statistic that says that more than 1 in 3 of the NHS staff are over 50 years old, which presents challenges in terms of attrition rate and burnout. And we also have a huge amount of the NHS budget being spent on staff. And these are trained staff who are highly skilled in what they're doing, and can put the vacancy rate and the attrition rate and the expenses together, you've got a perfect storm coming our way. If you were to look at the causes of burnout within physicians, which is only one part of the workforce, the senior clinical workforce is seriously being hurt by some of these factors on show here. The top one, which won't surprise many, is the amount of bureaucratic tasks, the charting, the paperwork, everything is run by paper, and also the fact that the huge amount of time, as alluded to in part one, is spent gathering information. Now, within here, you also see that on point number 4, where there is increasing computerization, which also adds to pressures to the staff. But if user-designed principles are applied to our electronic digitization journey, then there is a strong opportunity for us to minimize that. There are lessons from the past as to how you might do things and manage change. But the biggest factor by far here is the amount of paper-based working that's currently in play within NHS. Now, we have in Wales always competed with England, if you like, for recruitment. The same staff have the choice of working in England or in Wales, and Wales have gone further in trying to attract more medical recruitment, certainly with different styled contracts, which are slightly more attractive. But despite that, Wales suffers with chronic recruitment challenges, and particularly so across in northern Wales. Here you see the offer from England is that this is the current position. 85% of all NHS care providers in secondary care are already making significant strides towards full digitization. Only 15% are left to lean heavily on paper. Whereas in Wales, I fear to say, all the health boards are heavily reliant on paper case notes. And England is now focusing on leveling up, bringing those 15% up towards 100% target. And there is a transformation agenda ongoing, which is focusing on convergence, if you like, of all the legacy systems, and interoperability is being focused on. And HIMSS is a electronic medical records adoption model which categorizes levels of digital maturity of organizations from a range of 0 to 7. And there's a clear articulated aspiration of all English trusts to move towards completion of level 5 maturity level by March 2025. Now, that's a clear timeline, clear target, and there's an action plan in place. Now, in Wales, we're going to have to compete with that if we're going to appeal to the same workforce for recruitment. Now, we're compounded by the fact that our own digital assessment, HIMSS assessment of digital maturity, has come out at level 1 for a variety of factors of key pieces of the puzzle missing. And I think if we're there in level 1 in 2023, we could get to level 6 in 2028 if we got some of the key steps in the right order. And I think that's there for the taking. We have to struggle currently to recruit physicians and variety of specialists and variety of grades of doctors when the English offer is far more attractive as things stand, but we need to turn this around. I'm going to pass this on to Dylan to make his final remarks, and we'll have a discussion. Thank you.
Thank you, Ambu. That was good. Yeah. So, any comments from you, Sean, in terms of what's been presented?
I think I'd just like to pick up on one of the earlier slides that Ambu's shown around some of the recruitment retention figures. One of the starting things there to me was the 1 in 3 NHS employees are over the age of 50. It makes me start to think about the new generation of clinicians embarking on a career in the NHS and walking through the door of our health board are being confronted with an almighty mountain of paperwork when, you know, the flip side of that, their personal life is completely digitized. So it must be disheartening to a degree.
Absolutely. We hear this from junior staff all the time, and they are the digital generation, and they come in expecting a certain level of digitization, which is the norm in their other facets of life. I'm on the wrong side of 50, but even senior clinicians I speak to are continually telling me that they're frustrated with the current systems in place and the lack of safety and joined up arrangements. And I alluded to the information gathering as a challenge in part 1, and it remains a huge source and a source of frustration and a drain on our time resource. And you know, change management, even of the senior physicians, is not as bad as is projected in some quarters, as senior clinicians are harder to, you know, teach new tricks, etc. But I think we're ripe for change, embracing the newer digital agenda that's coming through.
Yeah.
So I think we're there.
I think, and the other thing to note is that the HIMSS assessment assesses the functionality that's available from our EPR systems. And by EPR systems, they can be multiple systems or one combined system. There are different approaches for